Let's start with pediatric oral surgery or pediatric oral surgical procedures. Now, before starting with the oral surgical procedures in periodontics, let's know what is a local anesthetic, what are its functions, its compositions, its type, and what are the various methods of inducing local anesthesia in children and adults. So what is basically a local anesthetic? It is basically a solution which we inject in the oral mucosa, and the circumscribed area of the body or the site of injection gets numb or it gets anesthetized. It is due to failure of the conduction of the nerve impulse or depression in the excitation of the nerve, that is particular nerve which is anesthetized. Now, what are the desirable properties of a local anesthetic? First of all, which is the most important, that it should be biocompatible. It should not be irritable to the tissues in which the local anesthetic solution is injected. Next, it should be like non-toxic to the tissues. It should not pose any systemic toxicity to the tissues in which it is induced, or any systemic toxicity or the after effects or the consequences in the body. Next, the onset of action, like it should be immediate in action. Like if we inject local anesthetic in a particular part of the mouth or the oral cavity, and we find the onset or the starting of the action effect of local anesthetic very delayed, then it will not be a proper or ideal characteristic of a local anesthetic solution. The ideal characteristic is the onset of action should be quick and fast. Then it should be effective also. For example, if we inject a local anesthetic and we do not find the desired anesthesia, then what is the use of injecting it? So it should possess, or it should pose its effect on the tissues into which it is injected. So it should be non-toxic, it should be non-irritable to the tissues, that it should not cause any hematoma or necrosis in the tissues in which it is injected, or cause any local necrosis. So it should be biocompatible, it should be non-toxic, it should have a great onset of action and the duration of the action should also be prolonged, but it should not be as more prolonged than the procedure. Like if the procedure is going to be conducted for an hour or 15 or 20 minutes, the duration of action of the local anesthetic should be long or last that duration. Now let's know what is a classification, or accordingly to what types the local anesthetic can be classified. They can be classified either into esters and amides, then quinolones. The esters are further divided into those which are derived from benzoic acid and those which are derived from the para-amino benzoic acid. Now let us know which of the local anesthetic solutions are derived from the benzoic acid. They are the benzocaine, then the cocaine, the tetracaine. Then comes the para-amino acid derived this local anesthetics. These are the procaine and the chlorprocaine. Next comes the amides. The amides are basically bupivacaine, then lignocaine, then mepivacaine. Then comes the quinolones. The quinolones are centrobutyrate. So these are the various type of the classifications into which the local anesthetic solutions are further divided. Now let us know what is the composition, or what does a local anesthetic solution comprises of. So basically it is a solution, so it will contain water. Then to maintain the isotonicity of the solution, it will contain sodium chloride. Then the local anesthetic, what is the main ingredient, that is the local anesthetic solution, is a local anesthetic. This is usually the lignocaine, which is 2%, then mepivacaine, bupivacaine, benzocaine, and either ester or amide type of local anesthetics. Then the function of this local anesthetic solution is called the effect of the numbness over the particular area, or the blockage of the nerve impulses in that particular area. Then comes the vasopressor drug, which is another main constituent of a local anesthetic solution. Now, what does this vasopressor contains? This basically contains either adrenaline or phenylephrine or epinephrine. Now, what is the function of this vasopressor? It is a vasoconstrictor. So, it reduces the blood supply or reduces the blood loss from that particular area. Since it is a vasoconstrictor, it also reduces the toxicity by reducing the absorption of the local anesthetic solution by the bloodstream. Then it is also increase the effectivity or the duration of the action of the local anesthetic. So first of all, it reduces the blood loss, it decreases the absorption and increases the duration of action of that particular local anesthetic. Then is the antioxidant. Now, the main function of the antioxidant is to maintain the vasoconstrictor drug in the local anesthetic solution, because it's the more probability of a vasoconstrictor drug to get oxidized. So this thing or this antioxidant, it prevents the vasopressor from being oxidized. So it is basically sodium bisulfite, which acts as a antioxidant for the vasopressor. Then I've already told the function of sodium chloride. Then is distilled water, which is a medium for suspending all local anesthetic constituents. Then a preservative, which is methyl paraben. So methyl paraben has a probability of acting in allergic action. So before injecting a local anesthetic solution in the mouth, we should always do an allergy test or a patch test in the forearm of the patient. This will prevent any further allergic reactions, or it will be like a warning if the patient is allergic to the methyl paraben constituent of a local anesthetic. So it also acts then as a preservative agent, and it prevents the bacteria from multiplying in the solution and is a bacteriostatic agent. Then is a fungicide, which is the thymol, and it prevents the this culture or growth of the fungus inside the local anesthetic solution. Then is a local various types of local anesthesia techniques. So various type of local anesthesia techniques are either block or infiltration. So infiltration can be also various types. The infiltrating injection, it can be any subperiosteal, that is, it should be above the periosteum but inside the skin and the tissues. Then comes the intrapulpal, that is, we directly inject the local anesthetic solution during any pulp therapy procedures like pulpectomy, pulpotomy into the pulp. When this happens or this injection is given, generally when other methods fail, then is the intraligamentary, that is, the local anesthetic solution is injected directly into the periodontal ligament. So this will prevent the conduction of the nerve impulse to the periodontal ligament. Then is a local infiltration, and the intraseptal injection, which is given inside the interradicular septum. Sometimes it is generally given during the time of extractions. Then comes the nerve block. There are various types of maxillary nerve blocks, that is the anterior superior alveolar nerve block. Then comes the posterior superior alveolar nerve block, the intraorbital nerve block, the greater palatine nerve block, the naxopalatine nerve block, and the maxillary nerve block. So basically, the nerve block function is to prevent or anesthetize the part or the starting or the initiation of the nerve and its branches. So it will anesthetize the entire area in which the nerve supplies. So it will further anesthetize the skin, the periosteum, the tissues into which, or the teeth, which is supplied by the nerve. So this is the function of the nerve block. So let us come to the techniques of the maxillary nerve blocks. First of all, this is a posterior superior alveolar nerve block. So with the nerve which is anesthetized by this particular nerve block is the posterior superior alveolar nerve, which supplies the posterior part of the oral cavity, the posterior teeth, the molars, first molar, the second molar, the third molar, then the buccal periosteum and the buccal tissues which are buccal to these first, second and third molar. but it does not supplies the mesiopalatal or the mesiobuccal root of the first molar or the maxillary first molar. So to anesthetize this root, we have to give another the injection or the local anesthetic technique. Now, the areas anesthetized I have already told. What are the indications whenever the surgical procedures or the extractions of these molars are indicated? Then we go for this injection. The main advantages of this injection, it is an easy technique, a very less amount of the anesthetic is required and less number of penetrations, but sometimes there may be complications of trauma and there may hematoma in the particular area. So what is a technique? Now let us see the main technique of this the inferior and posterior superior alveolar nerve block. So we basically take a 25 gauge needle, and this is a short needle which we take, and first we find the various landmarks which are associated with this posterior superior alveolar nerve block. The various landmarks are the maxillary tuberosity, the zygomatic process of the mandible, then the mucobuccal fold. The mucobuccal fold is the area which is present inside the cheek or inside the buccal mucosa. This is called the mucobuccal fold. So the mucobuccal fold, the posterior surface of the ramus of the mandible, the coronoid process. Then and this there is a zygomatic process of the maxilla. Then the molars, it is given adjacent to the second molar teeth or distal surface of the second molar teeth. So we palpate these anatomical landmarks. So we retract the buccal mucosa, and we take the needle or we insert the finger inside the buccal sulcus or the mucobuccal fold, and we rotate our finger so that this this bulbous end of the finger will end into the mucobuccal sulcus and it will point the coronoid notch. Then we'll place the injection, and we should keep in mind that during this injection the maxilla should be at an angle of 45 degree to the mandibular plane. So we'll insert the needle at the point like in parallel to the finger which is injected. Then we'll turn the needle so that it is 45 degree to the sagittal plane, and we'll locate this notch or the maxillary notch and the maxillary tuberosity, the zygomatic process of the mandible, and we'll then inject the needle into that area. So the direction of the needle should be upwards, then backwards and inwards. So these are the direction of the needle. Then we'll aspirate and finally we'll inject the local anesthetic solution. The basic signs and symptoms, it does not have any subjective signs and symptoms, but the objective ones, there is a loss of like pain during the operation. Complication may be hematoma or the mandibular anesthesia. Sometimes the mandibular nerve can be anesthetized. Then comes the nasopalatine nerve block. Now, the nasopalatine nerve block is generally indicated when the procedures of the incisors or the canines are involved. So, it anesthetizes the entire mucosa which is adjacent and the teeth and the roots and the pulps of these teeth which are present in the anterior area of the oral cavity. So, the canine, the molar, the first central incisor, the lateral incisor will be anesthetized by this technique. So first basically we locate the central incisors and the rugae area. We'll first indicate this, we see the incisive papilla, and for this technique pre-anesthetic, like a pre-local anesthetic injection is required. 2 injections are required, which is first injected into the incisive papilla so that the injection will be less painful. Then we'll go for finding the incisive foramen by a depression inside the below the rugae area, and we'll inject the solution at a 90-degree area, the 90-degree angle to the palate or the anterior palate. Then we'll see that the area is anesthetized, that is the area will be numb and there will be no pain during the operation. There are certain advantages of this technique, that is a very less amount of local anesthetic solution is injected, less number of penetrations are required, and the main disadvantage is sometimes there will be more pain during the injection and there will be hematosis. So the makes basically landmarks I already told, the maxillary incisors and the incisive papilla. We discussed about the technique, then the signs and symptoms, and the complication can be sometimes necrosis of the tissue, and sometimes during forceful injections the LA might squirt back or it might shower back into the oral cavity. So there will be no injection into the tissues. Next comes the greater palatine nerve block. Now the greater palatine nerve block is basically used for anesthetizing the palatal areas or the palatal roots of the teeth, which is the first molar, the second molar and the third molar and the entire palatal area. So what is the technique behind this greater palatine nerve block? First, we locate the second and the first molar and the gingival line of the second and the first molar, the mid-palatine raphe which is present in the center of the palate and extends up to the posterior part of the palate. So this greater palatine foramen is located like 1 to 2 centimeters from the gingival margin of the second molars towards the medial palatine raphe. So we locate the greater palatine foramen, we inject the needle as possible at an angle of 90 degree to the palate. Sometimes there will be complications of hemostasis, necrosis, and there will be squirting back of the LA. It is a painful injection also, and but there are some added advantages, that it requires less number of penetrations and lesser solution, and it is a simple technique. It is simple to locate the greater palatine foramen. Signs and symptoms will be, there will be absence of sensation or numbness of the point of the palate, posterior end of the palate, and will be absence of pain. Sometimes there will be associated complications of hematosis and necrosis, ischemia, discomfort, and failure to obtain local anesthesia as well. Now let us progress to the mandibular nerve block techniques. So these mandibular nerve block techniques can be either the inferior alveolar nerve block, the mental nerve block, the mandibular nerve block, and the incisive nerve block. So let us see or discuss what is the inferior alveolar nerve block. So basically, this inferior alveolar nerve block is responsible for anesthetizing the mandibular posterior teeth, that is the molars, the mesobuccal part of the first molar, and the buccal region, the palatal regions. The nerves which are anesthetized in the inferior alveolar nerve block is the inferior alveolar nerve, the buccal nerve, and the lingual nerve. Now, what is the technique for this inferior alveolar nerve block? It has two techniques basically, the direct technique and the indirect technique. Now, let us see what is the indirect technique. So, in indirect technique, we'll generally proceed from, suppose we require anesthesia in this quadrant or in the third quadrant, we'll proceed from the fourth quadrant. Now we locate the angle of the mouth and we locate the two premolar teeth. We'll start from the two premolar teeth. Now after locating the point of starting of the injection or locating of the syringe barrel, we'll then locate the area into which the injection solution has to be injected. Now first we'll hold the mandible from the posterior, from the thumb, or the posterior part of the mandible from the thumb, and we'll retract the buccal mucosa by the means of our forefinger. Then by the means of this forefinger end, we'll just locate the concavity or in the mucobuccal fold. So mucobuccal fold is one of the landmarks of this inferior alveolar nerve block. So by palpating the mucobuccal fold, then we'll go on palpating the external oblique ridge which is present in the mandible. Then we locate the coronoid process or the coronoid notch through which the mandibular nerve passes or the inferior alveolar nerve passes. Then finally we'll also locate the pterygomandibular raphe, which is present above the coronoid process, and we locate the external oblique ridge of the mandible, we locate the anterior border of the narandibule, and we locate there's a pterygomandibular triangle which is present, and the point of insertion of the needle is at the center of this triangle, and we generally see that this is located approximately at occlusal level or 2 to 4 centimeters above the occlusal level of the molars, but it is inverse in children. It is generally located below the occlusal level of the molars in children. So the point of insertion of the needle in children is a bit lower. So this was the indirect technique. In the direct technique, we proceed directly from the same point of the mouth or the oral cavity. We aspirate and then we inject 0.2 to 0.5 ml of the solution. There may be certain complications which can be linked to the inferior alveolar nerve block, that is there is a hematoma sometimes, and then there can be trismus, that is inability to open the mouth, and sometimes there can also be transient facial paralysis, that is if the facial nerve is injected with the solution, there can be a transient facial paralysis. But we'll also see if, like, we'll ask the patient whether the nerve block is effective or not. For the subjective symptoms, the patient will say that there is tingling in the lips and the part of the when solution is injected, then there will be tingling in the tongue also. So this was the inferior alveolar nerve block. Then coming to the long buccal nerve block. So basically the long buccal nerve block anesthetizes the buccal nerve or the long buccal nerve block. Then buccal nerve is also anesthetized by the inferior alveolar nerve block, but this is a long buccal nerve, so it will require another injection. In this, the landmarks will be second molar. It is generally injected distal to the second molar, and we'll palpate the mucobuccal fold, the mucoperiosteum, the coronoid notch, the retromandibular triangle, the external oblique and internal oblique ridge of the mandible, and the last molar teeth. So this will basically anesthetize the mucobuccal sulcus, which is present in the buccal mucosa towards the teeth, the vestibular mucosa, and the adjacent part of the buccal mucosa. We'll judge for the symptoms, sign and the symptoms. The subjective will be numbness of that particular area, and the objective will be lack of pain during intubation. The complications can be hematoma. Now coming to another easier nerve block, which is a mental nerve block or the incisive nerve block. So this mental nerve block, this blocks the sensation of the mental nerve, and the mental nerve is where it is located. It is located beneath the premolar teeth. So they were from which it emerges from the mental foramen. So basically we inject the solution into the mental foramen. Now how to locate the mental foramen? We'll place our fingers directly into the labial sulcus, and we'll palpate. There is a concavity, if we move from the incisity towards the mandible body, there will be depression or the concavity just below the premolar teeth, and directly we'll inject the solution by the means of a syringe into this concavity or below the apices of the premolar teeth. So the mental nerve will be blocked. So this is known as the mental or the incisive nerve block. So basically, what are the indications for this mental nerve block? Whenever any restorative procedures or pulp therapy procedures or extractions are required for the incisor teeth or the premolars or the canines, then we go for the mental or the incisive nerve block. Sometimes, and there are any contraindications for all these local anesthetic solution injection and nerve block, that it should not be any site of inflammation or infection at that particular site, because this will prevent, or there should not be any abscess or pus. This will prevent the action of the local anesthesia. The advantages, that is a high rate of success, a very less point of solution is required. It is an easy technique and usually atraumatic. Then there are certain disadvantages that it can also lead to sometimes necrosis or sloughing of the area, and there can be partial anesthesia which can develop in the midline. Sometimes it also does not produces any lingual anesthesia. And we have already discussed subjective signs and symptoms. There will be tingling or numbness sensation in the particular area of the lip and particular area of the mucosa. There will be lack of pain during instrumentation, and the complications can be hematoma. Now, after these nerve blocks and the infiltrations of the local anesthesia, let's progress to the topical anesthesia. The topical anesthesia is usually used either in a gel form or in a spray form. It is usually done before injecting the local anesthetic solution so that the particular area is numb for the point of time. It will only act for 2 to 3 minutes and the onset of action is in seconds, and this will prevent the pain from pricking of the needle during the site of injection. One of the most advanced form of topical anesthesia is EMLA, which is eutectic mixture of local anesthesia. It generally contains a prilocaine and the lignocaine solution, that is in gel form. It will be a mixture of both of these, and the main suspension will be the oil phase in the cream. So we generally apply the gel to that particular area, and this will prevent any discomfort to the patient. So this is a good application in pediatric dentistry. It will prevent the child from feeling the prick of the needle. So this was developed with Clock et al. In 1986. Now, after discussing local anesthesia and details, let us progress to pediatric exodontia or extractions in pediatric dentistry. Now, what are the indications of extraction? There are many indications like any pulp therapy procedures in the anterior or the posterior teeth. Then any oral surgical procedures like mucoceal is there, for example, ranula is there, or any impaction is there, impacted teeth is there, supernumerary teeth is there, or the teeth which are required for the orthodontic extractions. For example, generally there will be extraction of the premolars for the orthodontic reasons. Then there will be over-retained teeth which needs to be extracted. Sometimes also the surgeries in the mucoperiosteum like frenectomy, etc. are required. There will be cysts or tumors which need to be operated in pediatric dentistry. But there are certain contraindications for this procedure of extraction. That the patient should not have any systemic disease or systemic heart disease. The patient should not be hemophilic generally. Very much precautions are required for a hemophilic patient extraction. Then the patient should be not have myocardial infarction or any type of debilitation. Then what is the technique? There are certain techniques which are employed in this exodontia procedure. First is the extraction or the forceps technique. The forceps are taken for, they have their particular forces for the maxillary teeth, then for the mandibular teeth, and these particular forceps are taken in the tooth and are firmly placed on the tooth as apically or as they can be put, and the tooth is extracted by various motions like either rotatory or buccopalatal rocking or torsion or torque. Then comes the open extraction or the transalveolar extraction. Whenever the teeth are impacted, we cannot just pull it out because they are present below the mucosa. So we need to cut the mucosa and the bone to uncover the teeth and perform the transalveolar extraction. Then is the odontomy. Sometimes there is certain breaking of the teeth is required for extraction. This is the odontomy. Then is the elevator procedure. That is basically by the means of elevator we loosen the tooth from the firm attachments and then we extract by the means of forceps. So the basic procedure in extracting every teeth is that first is the application of the Mohs probe to detach all the small periodontal ligament fibers or the gingival fibers which are circumscribing the tooth. So by detaching these fibers, we make it loose. Then after making loose this buccal or lingual mucosa which this holds the tooth, we can put the forceps down into the tooth as apically as we can, and we hold the tooth firmly by the means of a grasping motion. Then there are particular chair positions for different teeth. Then we rotate the teeth or we rock the teeth, and by the means of a proper forceps motion we extract the teeth. But sometimes certain teeth like second molars need to be, the socket needs to be expanded before the extraction so that there will be unhindered extraction and the roots will not break. So this can be done by the means of an elevator. And finally we extract the tooth. So there are certain motions for particularly different type of teeth. For example, the root of the maxillary incisors are conical. So we go for a rotatory motion and we hold the forceps firmly onto the tooth and then we go for a rotatory motion. We rotate the forceps back and forth and we finally pull down the teeth. Then is the lateral incisor in the same way. It has basically a flatter lingual and buccal surfaces, so it requires a lesser number of rotation. Then is a canine which has a longer root, so it requires a larger force to be removed, and by maintaining apical pressure and rotating motion we can extract canine. And then comes the premolars, which are absent in the primary dentition, but in the mixed dentition they are there. For orthodontic reasons they need to be extracted. So in the premolars and the maxillary, first premolars have two roots. So basically in this premolar we require buccopalatal motion. Then in the molars also we require the same motion, the rocking motion, the torsion, the torque, and the buccopalatal motion. And the third molar, it is a tricky one. So the third molar can sometimes be impacted. So if the cusps of the third molars are not exposed, there should be made no attempt or extraction of these third molars by the means of forceps, because they will go for impaction or transalveolar extraction. Then if the tooth, sometimes the tooth, the crown is more, it is buccally or distally placed and the roots are more anteriorly placed, so they need to be removed. If they are buccally placed, they can be removed easily, but if they are distally or more posteriorly placed, they need a tricky procedure. Then comes the mandibular teeth. The mandibular teeth are basically removed by the same motion. The incisors are removed lingually. They are moved by labial forces and apical pressure. The premolars are removed by rotating motion and the buccolingual motion, the torsion and the buccolingual motion, and same are the molars removed. So the roots require certain root forceps, or they also require wedging technique in removal by the means of the criers or the crier elevator. Then forceps and elevators are required for the removal of the root. Now, what happens in children? We have to go for various behavior management techniques before the extraction of teeth. They may be either show you that we have to tell the patient what we are going to do. We'll have to show the instrument to the patient and then to do exactly as we have told, so that we can win their trust. And in future appointments, the children will be handled easily. Then we can also go for reassurance to the patient, and modeling like the endless sibling can be shown on the extraction procedure. Then there will be other audio distraction methods or audiovisual distraction method. We can play a cartoon in front of the child so that the attention of the child will be diverted to the cartoon and he'll not pay heed to the extraction procedures. Then if all these procedures fail, there are certain aversive techniques like uses of physical restraints or bite blocks in the mouth of the patient, which will prevent the patient from closing the mouth, and this will help in the extraction procedure. Now there are certain universal post-operative instructions after extraction which are given to the patient. First of all, the patient has to keep the cotton in the mouth at least for 30 minutes to an hour so that the whole blood clot should be maintained. Next, the patient should take only semi-solid or liquid foods at the time of extraction, like 1 day, so that the clot will not be dislodged. Forceful sweating, forceful brushing is not, it is contraindicated in such patients, and taking of any hot beverages is contraindicated. And the kids also should always be kept in a close supervision, because there will be the duration of action of the local anesthesia will be long. So the kids might bite their cheek, their tongue due to numbness. They may get hurt. So these are the post-operative instructions are usually given to adults and children after the exodontia procedure. Thank you.